So I'll start with what is Care Innovations Guide. Care Innovations Guide is a system that allows a clinical team to reach into the home and provide timely and specific and personal interaction and feedback with the patient in the home. So the item on the right is our guide solution that goes in the home. You can see it's got a 10-inch color touchscreen. There's an example of doing a video conference between a physician or a nurse practitioner and the patient in their home. It connects to several peripherals, both wired and wireless, and allows collection of biometric monitoring. But at least as important, or perhaps more important, it drives in a very interactive experience with the user of the device in the home. We believe that ultimately this management of patients at home direction comes down to engaging the patient in a highly interactive, very tailored, timely, specific, and personal experience that is that's timely and specific to the situation they find themselves in today. So, for example, a diabetes patient with a blood sugar out of line needs some feedback, and they need that feedback to be specific. They need it to be personal based on their situation that they find themselves in at any given moment, and that's really what we've designed and developed our system around. I'll talk a little more about how that works. On the left side, you have the care manager who has a clinical dashboard. In fact, I don't have a photo of it here, but Trent showed it in his presentation. It was the red, yellow, green triage page, what we call the triage page, and that's the back end of the system. It's the virtual care suite, and that's where the patient information is ranked based on the need for triage from a nurse practitioner or a physician. And it's not just based on the biometric information. Again, we think the psychosocial aspect of the patient situation is as important as the biometric information. And so for example, questions about how you're feeling today compared to yesterday, questions about fatigue, these kind of things that we can't measure through a biometric device are equally important and are part of the algorithms that determine the triage order for the patients in the system. And then there's a set of patient education and protocols, ultimately driving towards a more self-sufficient patient. So being able to provide timely and specific and personal feedback and deliver education to the patient, which allows them to take a more active role in the management of their disease condition. And so that may be, if there's a challenge with blood sugar, a video, a 3 or 4 minute video, either one of the ones that we provide with our system, or something that that yourselves has recorded and actually pushed through down to the patient's device in their home, are explaining to them more about blood sugar and the measures that they could and should take to control it. Again, we offer a set of educational videos. We also offer the capability for their trusted advisor, their nurse practitioner, their physician, to record those themselves and move those down to the device in the patient's home so that they can be played at the right time to any given patient. So that's a high-level view of the technology. It's a very flexible platform built on Intel and GE technology. If we build to the next slide, the technology is wonderful, but ultimately the technology is only a piece of the puzzle. Really, this comes down to people and all the people involved. Again, we've spent 10 years in this space, and one of the things we did as Intel was we did a giant ethnographic study, and ethnographic studies are studies of how people operate and interoperate with equipment and other people. We've literally been in 1,000 homes. We have tens of thousands of hours of video of our target population interacting with their microwave and their VCR and their telephones and having phone conversations with their nurses, and really diving in to understand how people interact with technology and interact with one another in this healthcare setting, and then building technology in support of those interaction models. Again, we did that in 20 countries over 10 years, and you learn some fascinating things. I mean, some are intuitive. There are no good VCRs anywhere in the world, and we learned that. But more importantly, we learned how do you drive behavior change. Go ahead and build this slide out. One more click. So what we learned is how to drive behavior change, and we have this white paper that walks through that. Certainly contact us if you're interested in a copy of that. But why is behavior change important? You know, I've had myriad conversations with physicians and nurse practitioners that ended in a similar conversation, which is, you know, I know what this heart failure patient needs to do, or I know exactly what this diabetic patient needs to do, but if only I could get them to do it. And really, that's the premise of all of the technology that we build, is how can we create that connection? How can we give tools that can ultimately drive the lifestyle changes that help with the management of these diseases, and then give the clinical staff a dashboard to manage on an exception basis. And again, that's more of what Trent talked about. So, you know, quick statistic here, there are hundreds and hundreds of these kinds of statistics, but significant reduction in dietary sodium intake has a huge impact on CHD, on stroke, and on heart attack. Not something that we probably even need to put on the slide, right? I think that's fairly well understood, but it's key, obviously, that behavior drives health, drives cost. Let's go ahead and go to the next slide. One of the things that we learned is when you engage people in using persuasive imagery, videos, and persuasive still shots, that's a very effective way to drive their behavior. So, for example, putting an image on the screen at 11:30 like this will drive appropriate consumption at lunch. If you go ahead and build one more. Also, interacting with them in a quiz kind of style interactive, we can run this kind of quiz on the guide. Which of the following has the most sodium? On the right is a fruit and yogurt parfait. In the middle is Planters salted peanuts. And on the left is a bowl of Raisin Bran. And I actually learned this from the head of cardiology at a major university hospital here in the U.S. And if you build it out, obviously it's a trick question or it wouldn't be in here, but the answer is it's the Raisin Bran, and it's of course all the sodium preservative in the Raisin Bran. The key point is, by engaging patients with this kind of a interactive experience, and by the way, you can see whether they answered it correctly or not, you're able to drive them to think about the decisions that they make, and then build the last piece of this slide. Of course, what you follow up with on that same device is it's not always intuitive which foods have the most sodium. The way you should check is by looking at the FDA label and identifying the specific amount of sodium. So this kind of experience drives a level of education and a level of knowledge which allows patients to transition to more active role in the management of their own disease. Go ahead to the next slide. Go ahead and build this out. I think it's 3 clicks. One of the things that's really important about engaging patients is that the material that they're getting is specific to their situation, and we look at the protocols that are necessary to manage a given set of patients as building blocks, kind of Lego style. And you can see here Betty and George, you know, they may have some similarities, but they've also got some differences, and every patient is unique. And so it's key that you can deliver protocols and education to the patients which are specific to their situation. And those Lego building blocks are put together within that system that Trent showed us earlier in the virtual care suite. In the interest of time, let's keep building this out. This is an example of a protocol that we've worked on with in partnership with the American Diabetes Association. And so this would be kind of the base solution for patients with diabetes. As an example, Betty, 72 years old, type 2 diabetes, she would get a guide with the peripherals, the personalized program, which would be based on the ADA's protocol, and then in addition, we could add things like, you know, smoking or other preventative health items, as you can see there, sort of on the left, on the lower side of the description of what Betty's working on. And I think the quote under Betty is really key. Am I doing the right thing? By having a solution like this, where first the patient can become more educated, and second they can reach out to their caregiver, the anxiety reduction alone is significant. And if you look at a physician managing a set of patients in their homes, you get the benefit certainly of the more educated patient with the real-time feedback to that patient. You also get the outreach and the reduction in anxiety ultimately drives more appropriate use of healthcare resources. Go ahead to the last slide. So what happens when you put all of this together? And importantly, you'll see we lead off this slide with a model of care that's delivered by a clinician. That's the key. A model of care that uses technology, which is built upon the way that people want to operate and the way that people effectively operate today. The guide in that context has been shown to impact behavior change, drive medication adherence, drive self-management, and ultimately where we're trying to get to, particularly with the Independence at Home pilot program, is to drive appropriate utilization of healthcare resources. And that's really obviously where we're driving to with this particular pilot. I believe that's my last slide, and with that I will turn it back over to Constance.
To me. Thank you. Well, thank you, everyone. It's now time for questions. We've left a significant amount of time, and to sort of, does everybody know where to type? There should be a question box in your on your screen where you can type your questions. I'll kick things off while people are collecting their thoughts. Dr. Margelis, would you like to tell us a little bit more about how these kinds of technologies are being used in Australia?
Sure. So we've got a couple of projects underway here in Australia, and we've been doing this now for a couple of years, specifically focused in, so Australia has a Department of Health and Ageing. The same department which manages our healthcare system also manages our ageing population, so that's a nice confluence. And they've developed quite a few programs where they provide home-based care, not just healthcare, but social care, care around the house as a combined package. And we've had a couple of programs where we've included a home monitoring technology using the health guide as part of that program. One which is about to be published fairly soon, where we had 50 patients using the home technology, average age of 84, all with at least one chronic disease, most with 2 or more. And what we found is a significant decrease in hospitalization, significant improvement in the quality of life for the patients, done through things like depression scores that showed significant improvements in their anxiety and depression states, but also the ability to collaborate. So the nurse who was coming in during the day was now able to do a lot of those things remotely, manage those patients, talk to the GPs who was looking after the patient in a just-in-time manner rather than a programmatic manner. And we found that the patients loved it, the clinicians loved it, and the costs really started to drop because travel time was taken out of the equation, unneeded consultations, just the system being streamlined was the key.
Good. Well, thank you so much, Dr. Margelis. Okay, this first question is to our one of our presenters from the GE Alliance. Are there plans from GE to pursue coding and reimbursement from insurance payers? Shall we?
I can address that. This is Marcus,
Hi, Marcus.
And actually we would love to see coding and reimbursement for these kinds of solutions, and we're working towards that end. We think the solutions have been proven and are working towards that end. Having said that, we don't think that we can wait as a system, a healthcare system, for coding and reimbursement. And in fact, where we're seeing adoption is in those areas where the customer base, whether it's a payer or a provider or an employer is really incented in a way similar to the Independence at Home pilot, where they have some benefit for bending the cost curve. Alice may be able to address more specifically the status.
Yeah, hi, this is Alice. Can you hear me?
Yes, Alice, we can.
Okay. Well, I think Mark has said it very well. The Affordable Care Act really starts moving us away from volume and to value and away from the fee-for-service schedule. So that's going to take a while. So we're still interested in playing in the current system with reimbursement, but we really have to take a forward-looking approach to coordinated care through accountable care organizations, IAH, and other programs that really press for coordinated care and bundled payments. And so IAH is one pilot. We're seeing a lot of different opportunities coming into the Innovation Center through their challenge grants. So I think most people know that, but I'll just reiterate, for those challenge grants that are accepted and prove their value, the Secretary will have the authority to scale those pilots nationwide. So we think there's some opportunity that we'll see over the next year or two coming from the pilots, depending on which applications they accept. So there's a lot of great activity, a lot of good conversation in this space, and we think it's really positively moving forward, but we're always looking at that reimbursement code as well.
Right, and on reimbursement, thank you, Alice. Dr. Margelis, there is a general question. Is there reimbursement for telemonitoring in Australia, and is it impacting the adoption of technology?
Sure. So there's a couple of reimbursement changes over the last 12 months in Australia that have really started to change things. Number one, we introduced in July last year reimbursement for remote consultations between a healthcare provider, a physician, and a patient. So now patients who live in non-urban areas, which is a large part of the Australian population because of our sheer size, now actually can be the physicians are reimbursed through the National Health Insurance for remote consultations. We've introduced reimbursement around packaged care, so chronic disease management programs are being provided with a bundled payment dependent on various criteria. So there are selection criteria for the patients, but those bundled payments enable the care team to determine the best way to deliver care. We have a number of large-scale pilots currently underway. Two exciting things in Australia. One, the healthcare reform, but we're also in the process of running fibre to every single residence and house and premise in Australia. So we're going to have a very high-speed national broadband network. And as part of that, we're actually doing a number of pilots demonstrating how a combination of home monitoring, video conferencing, and high-speed broadband can provide benefits. That's relatively early at this moment, but those projects are underway. But the key reimbursement change has been the concept of bundled payments around a management plan. Similar to your ACOs, we call them Medicare local tier, but that's been the big change in that we've now had a meteoric escalation in people starting to use remote monitoring. Again, most people are still trialing, getting their heads around it, working out how they integrate it into their clinical workflow, because it's not just plug it in and away you go. You need to understand and to some degree transform your clinical workflow to take advantage of it. But bundle payments and chronic disease management programs have made a huge difference there.
Hey, Connie, this is Jim, could I just add to what the last two speakers said? We designed the Independence at Home program so that it is not necessary to get approval for specific devices. Maybe you can certainly get that, and as Alice says, that kind of reimbursement will be with us for a while. But that's the kind of micromanagement by government bureaucrats that tends to stifle innovation. So the whole idea of having a rather robust savings sharing component to Independence at Home was to allow decisions about the technology to be purchased, to be made by physicians in conjunction with the patients. And it sounds like that's what the direction that Australia is moving in as well. I think you're going to see a worldwide trend in that. I see that also in the Western European countries. So so the idea is to get away a bit from the specific coding and specific reimbursement, and two, allowing more latitude for physicians and patients.
Good. This one is going to make its way back to you too, Dr. Margelis, but the others are most welcome to comment. The question is, it seems telehealth technology is mostly aimed at younger, more functionally elderly than our typical patient. This is IAH patient. What interventions do you propose for frail elderly with some cognitive impairments? For example, Dr. Margelis, what type of cognitive measure was used to determine if patients could properly utilize the home monitoring system studied? Was there a particular educational level needed to operate the system? Why don't we start, Dr. Margelis, if you would, with you, and then go to everyone else on that one.
Sure. So I mean, there's a common assumption that elderly patients cannot use this technology, and I must be honest, when I first started in this game, I had a similar belief. The pilots we've done here in Australia, the average age has been well and truly into the 80s. Most of these people have never touched a computer before in their life, and literally with 15 to 20 minutes of very basic training, they're up and running. Cognitively, most patients had some degree of mild cognitive impairment. I mean, we didn't have any full-blown dementia patients. We did have a selection criteria based on the nurse who was evaluating the patient, that they deemed the patient to be suitable. But generally, they all had at least a mild degree of cognitive impairment, which is common in that age group. The technology has to be simple to use, so we don't give them a laptop computer and say log in. It literally is an easy-to-use touch screen, big buttons, voice added onto it for support. And the experience has really been that of those 80-year-old plus patients who have all the standard issues that we face with an 80-year-old population had no trouble using it. Compliances were in the high 90%. Patients were actually disappointed when they stopped using it. And one of the comments they made, and we actually have a couple of videos, and you can probably have a look at YouTube for the videos from the pilots here, of the patients talking about how easy it is to use. The key is not to pitch it as a technology solution, but pitch it as part of their overall healthcare solution.
If I could chime in on that, this is Trent with My Doctor Connection.
Yes,
we actually did a small little field test in the Villages, which is in Florida. It's the largest senior complex in the nation. 70,000 seniors in one location. They're building out to 120,000 seniors. Huge, huge population there. And one of the most popular places in that entire complex, there's 4 of them, is that area where you can take your laptop, you can take your computer, you can take your other technology and link in. And people, they use the technology because that's what their grandkids are and that's what their families are. But George is exactly right. If you tell someone that here's a laptop and here you go, you're not going to have as strong a compliance as the beauty of the Care Innovations My Doctor Connection machine is. It's touch screen, and it tells you audibly and visually what to do. So it's not like they're really on a laptop, but it can create that communication just like they're out on the World Wide Web by the educational moments and the interaction with their care team and their family. That people get that, and they understand this is not a laptop. This is something that's going to save their lives and help their health, so they can enjoy life, so they can go from reactive to being proactive.
Good. Well, thank you so much. There are a number of questions to you all that have to do with your pricing structure and how somebody might access the products that you have. To everyone who's asked that question, and there are a number of you, I would suggest that you email the presenter directly. Is that all right with all of you? Rather than trying to, because we don't have time to go through all of this on this call. So all of the contact information for the speakers is on their slides. So go back over it. I'll end the question part before I have to start by just saying that with just one, how is the security and privacy of the patient health situation kept to a minimum? Would somebody like to pick that one up, maybe who hasn't spoken so far?
Yeah, this is Michael Phillips. I mean, we definitely understand the privacy issues. We do not transmit any personal health information when we're transmitting data both to the patient or the individual or when the individual is replying back. So, and then in our web portal and with our HL7 interfaces, they all are verified and tested for security measures, and we use all the standard technologies to confirm that.
Right. And generally, there is a general question about the integration of the technology, integrating with various people's EMRs. There's one question with Centricity. We're not going to have time to answer that one, but again, if you would ask specific questions of the presenters like that, does it integrate with this or that? That would help. The last group of questions have to do with the IH application process itself. I would suggest that those people send those questions to me at aahcp@comcast.net, and I'll be happy to answer those, but not on this. It is now, in fact, 3 o'clock. We are going to post these slides and the recorded sessions on the AAHCP website. So if you have friends or neighbors or people who would like to see this again, please feel free. You also will be sent a brief evaluation form we hope you will fill out to give us some guidance. And now, since we can't all clap, I just want to thank all of our presenters so much for taking time out this afternoon. Thanks to Alice, thanks to Jim. And with that, thank you so much for coming. Bye-bye.
Bye-bye.
Thank you,
Thanks,
Connie.
everyone.
Bye-bye.
Thank you.
Bye-bye.